Hello, today we'll talk about rabies infection. A 9-year-old girl presented with 4 days history of fever and pain over the upper third of left arm. It was associated with numbness over the same area. The patient developed tremors of the left arm, which later progressed to involve the other parts of the body. She also had difficulty in swallowing liquids and developed hydrophobia and aerophobia. Further probing revealed a history of dog bite a few months earlier. The most probable diagnosis and how can this be prevented? That's a quite straightforward question. Coming to the etiology, rabies virus is a bullet-shaped virus with a negative sense single-stranded enveloped RNA virus from the family of Rhabdoviridae, genus Lyssavirus. Theoretically, rabies virus can infect any mammal, but usually it is seen in terrestrial carnivores and bats. Rabies virus is found in large quantities in saliva of the infected animals, and the transmission occurs most of the time through bite or licking on the wounds and is passed through the saliva. Although there is a theoretical possibility of human-to-human transmission through the same route, there is no documented cases so far. But however, full barrier precautions have been recommended while taking care of a rabies patient. Coming to the pathogenesis part, after inoculation, there is slow replication of virus in the muscle or skin. It enters the peripheral motor route, and then there is a fast axonal transport, rapid dissemination throughout the brain and spinal cord, and then the virus travels back in the anterograde fashion through the peripheral nervous system to all the innervated organs, and this exacerbates the dysautonomia, and this is the route by which it reaches the salivary gland. The infection of dorsal root ganglia is apparently futile but causes the characteristic radiculitis. Infection concentrates in the brain stem, accounting for the autonomic dysfunction and relative sparing of cognition. Usually the rabies patients are conscious, they know there is something wrong with them, but there is severe autonomic dysfunction. The pathological hallmark of rabies is Negri body, which is composed of clumped viral nucleocapsids that create cytoplasmic inclusions on routine histology. And in a documented case of rabies, Negri bodies can be absent. It is usually seen, but it can be absent. Coming to the clinical features, the incubation period is actually widely variable. The average is 1 to 3 months. When the wound is closer towards the brain, when it is on the head, it can be as short as 5 days and it can go as high as 8 years. Now coming to the clinical features, there are two types of rabies. One is encephalitic or furious rabies, and the other one is paralytic or dumb rabies. The one which is usually seen or demonstrated or being shown is usually the encephalitic or the furious rabies. It begins with fever, sore throat, malaise, headache, nausea, vomiting and weakness as for any viral infection. And then there can be paresthesia and pruritus at the site of bite, which extends along the limb. Soon, once it reaches the brain, it shows some symptoms of encephalitis. The patients with rabies encephalitis initially have periods of lucid intervals, alternating with periods of profound encephalopathy. Hydrophobia and aerophobia are characteristic signs of rabies, and they are unique to humans, and it may not be present in all the cases. Seizures are rare, and if there is a seizure, you should probably think of other diagnosis. The illness is relentlessly progressive. Once the symptoms have started, there is no return. Paralytic or dumb rabies, it is seen very much less frequently. It is characterized by fevers and eccentric motor weakness affecting both limbs and the cranial nerves. They have some element of encephalopathy as the disease progresses, and the disease progression is quite slow. Detection RT-PCR of RNA in saliva, skin and brain. Rabies antigen can be detected through immunofluorescence of saliva or biopsies of hairy skin or brain. Corneal scrapings were used earlier, now it is not recommended. Antibody in CSF is considered to be diagnostic of rabies regardless of the immunization status. Neither rabies immunoglobulin nor rabies vaccine provides benefit once the symptoms have appeared. So practically the treatment for rabies is nil. Milwaukee protocol, Brazilian protocol have all been tried. There is a rare chance of survival once the symptoms of rabies have already started. Even if they survive, the neurological outcome is going to be very poor. Prevention is the best method. Vaccination of all domestic animals, and for people who are at risk, who are coming in close contact with these animals, pre-exposure prophylaxis with intramuscular injection at a deltoid or anterolateral aspect of thigh with anti-rabies vaccine on day 0, 7 and 28. Post-exposure prophylaxis. First of all, proper cleaning of wound with soap and water. Use disinfectant if available. Primary wound closure is avoided. Antibiotics and tetanus injection if you feel that it is contaminated and depending on the tetanus vaccination status of the patient. You got rabies immunoglobulin, which is infused around the wound, the maximum quantity around the wound. The calculation is 20 international units per kg, and the rest of it, which cannot be infiltrated around the wound, is given as IM injection. The latest one is rabies monoclonal antibodies, which is infused around the wound at the rate of 40 international units per kg. It is a mixture of docaramimab and niromavimab. Monoclonal antibody is the latest addition to the fight against rabies. So it is either immunoglobulin or monoclonal antibodies, along with simultaneous administration of rabies vaccine on day 0, 3, 7, 14 and 28. So total 5 doses, and in immunocompromised patients, a 6th dose is recommended. There are different vaccine preparations available: purified duck embryo vaccines, purified chick embryo cell vaccine, human diploid cell vaccines and purified vero cell vaccines. Coming to the MCQs, Negri bodies are intracytoplasmic. We are already mentioned, it is basophilic intracytoplasmic. All of the following rabies vaccines are commercially available except recombinant glycoprotein. All the other 4 we have already mentioned. Which antigen of rabies vaccine stimulates antibody protection? It is glycoprotein. In rabies, the characteristic pathological manifestation is, we had already mentioned it, it is very important, it's brainstem encephalitis. The speed of rabies virus in axon is 3 mm per hour. It is quite rapid transmission through the axon. That is 3 mm per hour. The notes were prepared based on Nelson textbook and OP guide. Thank you.
Docemy.